Right, now for a different sort of challenge, what I've been talking about so far were, in a sense, I'll call them technical challenges. If you're trying to get an unbiased estimate of cost effectiveness, that series of challenges I've just reviewed, they all arise. They're obstacles to getting a robust estimate of cost effectiveness. So they're obstacles to producing the data. They're obstacles to producing the number, the result. The next set of challenges are challenges involved in using economic information, so not the creating of it, but using it. Once information exists, the challenge is involved in using economic information to inform decision making. And here's a few. First one, and I mentioned this just in passing, increasingly regulators are approving therapies at earlier stages on the basis of less robust evidence. So, for example, a European Medicines Agency used to require what's called phase 3 studies. These are quite large studies, randomized to the intervention and to the control group. Increasingly, they are willing to approve a new drug on the basis of phase 2 data, which may well be a single-arm study where all the patients got that therapy. Now, for the purposes of drug safety, that might be all right. You might be able to form a reasonable judgment as to how safe the drug is by looking at a single-arm trial. But for purposes of economic evaluation or purposes of obtaining value for money in your decision making, that sort of data is much more limited and much less helpful. For all the reasons when I was talking about indirect treatment comparisons, we would rather have a randomized head-to-head trial. So that's one challenge. And the challenge is this, that with the regulators approving drugs at an earlier stage, there's a real pressure on the health technology assessment bodies to make decisions at an early stage. Another challenge is what we might call the clustering of health technologies.
Is there any feature of those drugs that are being approved earlier? Are those drugs targeting, for example, special conditions or rare conditions that are not really having any other alternative for treatment, for example?
I think that's a fair point. I think not always, but on a significant number of occasions, these will be conditions where current therapies are either absent or noticeably poor. And so we don't want to wait a long time for a new therapy. If something seems to be working and seems to be safe, we want to get it approved more rapidly, which is perfectly reasonable, but it means the decision making is being made on the basis of much more limited data. And there's an appreciable risk that from a health sort of safety point of view, we could be making the wrong decision because the phase 2 data typically is a much smaller study, and it may be that some of the bad outcomes are relatively rare and you need a bigger study to capture them. But yes, there can be quite persuasive reasons for earlier decision making. Equally, I think there's quite a strong commercial push as well, because it is very costly to develop and thoroughly test new drugs. If you can get them approved sooner, you can as it were, get the payback sooner. If you can get them approved sooner, you don't have to do quite so much testing, and you can therefore reduce the costs of drug development. So there's that as well. Okay, clustering of health technologies. This can be, I think I've got a slide on it coming up. This can be a bit of a challenge. By clustering, I mean, if we stick with the drug example, several related new drugs coming along almost at the same time or one after the other. Now that causes all sorts of problems, particularly with respect to comparators. We'll see an example in a minute. Another challenge involved in using economic information is achieving and maintaining stakeholder engagement. I touched on this, I think, on Tuesday. There's not much point looking at the cost effectiveness of new drug if you aren't going to say no sometimes. If you're always going to say yes, don't bother looking at cost effectiveness. The information is no use to you. It's only useful if you're going to say no sometimes. If you're going to say no, you've immediately got a problem with stakeholders. The stakeholders here are predominantly the manufacturers, clinical groups, patients, patient groups, although arguably also the general public are stakeholders. And so if you're saying no sometimes, how do you ensure that you're not alienating, driving away your stakeholders? How do you keep them involved? So there's a challenge. Another challenge is introducing economic information to decision making. It requires a lot of capacity in the system. It requires capacity to produce economic evaluations. It requires capacity to critique economic evaluations. You have to critique them. You can't just take at face value somebody says this is cost effective. It's got to be critiqued. And then among the decision makers themselves, it requires capacity to interpret the evidence. What does it mean? Now, we might all think, well, we know what £25,000 per additional QALY gained means, but it's not what the headline means. It's to what extent can we rely on that number? And to understand that, you need to have some understanding of how the number is being created. And decision makers need that. So that's quite a lot of capacity that doesn't exist naturally in the system. I mean, if we took the context of Japan, if Japan really wanted to embrace health technology assessment on a big way, you're way short of adequate capacity to I mean, I think small steps are fine, but it'd be quite difficult to move rapidly to a routine evaluation that involved economic information. And then the final challenge I've got here is that there's a need, or we need, the budget set for healthcare and the cost effectiveness threshold that's selected to be consistent with one another. This is the affordability issue. If they're not, if the budgets are out of sync with the cost effectiveness threshold, you're going to create problems rather than reduce them. Well, I've got a little bit more to say about some of these.